Auzubillahiminashaitanirrajim. Bismillahirrahmanirrahim. Hello dear ladies and gentlemen, today we will discuss about neurological examination, state of consciousness and orientation. If normal, the patient is fully conscious, oriented to time, place and person of average intelligence and cooperative. On second stage, we will recognize him from his speech. So, aphasia, inability to formulate speech, diphtheria, difficulty to articulate speech property. Now we are coming to note about his cranial nerve. On positive, we will come uptake, acute of vision, use finger counting from a distance of 6 meters. If the patient failed to count the finger, use hand movement. If still does not see the movement, use light perception. Field of vision, use confrontation test. Now we are coming to discuss oculomotor pupils, nerves. Examine light reflex of 2 F3 for each eye separately. Now and then examine his facial motor part. Upper face test for foam closure of the eyelid. Lower test for whistling, blowing the cheeks and showing the teeth. Observe for the absence of nasolabial fold. Dropping the angle of the mouth. Then examine his sensory part. Examine for taste sensation over the interior 2 to 3 of the tongue by applying drop of sweet. Then inspect the uvula. Normally it's central. If it is deviated, it's then glosso toward the healthy side. Pharyngeal reflex of CR9F CRLO. Pharyngeal touch the posterior pharynx while depressing the tongue. Then vagus gag reflex, exaggerated gag reflex, pseudo bulbar palsy. Then NB, how to differentiate between UMNL and LMNL of facial nerves. UMNL facial nerves are paralysis of MS of upper and lower halves of the face on the same side of the lesion. Associated hemiplegia on the opposite side of paralysis. LMNL facial are paralysis of lower 112 of the face on the opposite side of the lesion. Associated hemiplegia on the same side of paralysis, cross hemiplegia, or confrontation test. LMNL palsy, facial palsy. Motor system of the body are inspection, muscle tone, muscle power, reflexes superficial or deep. Inspection, this is a picture in which we shown a paralyzed child, spastic child. State of muscle, fasciculation, abnormal position, tropic changes. Then we will examine his state of muscle, unilateral or bilateral wasting or hypertrophy or fasciculation. Inspect for fasciculation in unsupported tongue. Its presence, wording, Huffman disease, AHC lesion. Abnormal position. Abnormal position is a frog-like position in hypotonia, schizoid in spastic paraplegia, tropic changes. Then we will examine his muscle tone as we shown in the figure. Shaking method for ankle, Gore method for shoulder, test for muscle tone, phasive flexion and extensive for all joint, shaking method for wrist and ankle, Gore method for shoulder. Your comments either hypotonia, hypertonia, normal tone on each side, upper or lower limb. Then examine his muscle power in the upper limb, shoulder, abduction and abduction, adduction and abduction, flexion and extension, lateral and medial rotation, elbow. As we shown in the figure, extensor of elbow, flexor and extension, wrist, flexor and extension in the lower limb, hips. As we shown in the figure, abduction of hips, flexor of elbow, flexion, extension, adduction, abduction. Knee, as we shown in the figure, flexion of the knee, extension, flexion, angle, dorsiflexion, plantar flexion, should be examined bilaterally, comparing both sides. Reflexes, deep reflexes, the upper limb, bicep reflexes C5-6, brachioradial reflex C5-6, tricep reflex in the lower limb, knee reflexes L2-3-4, ankle reflexes S1-2, superficial reflexes, plantar reflexes SI2, stroking the sole of the foot with a blunt object result in the plantar flexion of the toes. If there is dorsiflexion with or without planing of the toes, it denotes UMNL. Abdominal reflexes, stroking the abdominal gently from outside toward the umbilicus on both sides of the three different level. Normally, the umbilical moves toward the stimulus if loss equal to UMNL, as we shown in the figure. Bicep reflexes, brachioradial reflex, plantar reflex, knee reflex, ankle reflex, tricep reflex, superficial abdominal reflex. Your comments either are hyporeflexia, hyperreflexia, normal reflexes on each side, upper and lower limb. If there is hyperreflexia, proceed to test Clonus and the other pathological reflex. Now we are coming to discuss to examine about Clonus. It is the rhythmical series of the contraction in response to sudden sustained stretch of muscle tendon. Annual Clonus less obtained by passive plantar flexion of the ankle, followed by the sudden dorsiflexion. Flatular Clonus is obtained by progressively depressing the patella with a quick movement after gentle upward placement while the leg in extension and relaxed tips. Only sustained Clonus suggests UMNL. Other pathological reflex. Adductor reflex L2-4 with the patient supine place the limbs in the light and slight abduction. Diacritically tap the adductor magnus tendon just proximal to the insertion on the medial epicondyle of the femur. Flatular reflexes L2-4 with the knee extended with and the limb lying on the table. Push the patellar tendon distal with your index finger on the insertion of the quadriceps tendon as we shown in the figure. Downward on index finger. Adductor reflex as we shown. Now we are coming to examine about sensory system. Superficial sensation. Compare both sides, legs to legs, arm to arm. Compare on each side the LL with the trunks, with UL with the face. In case of hypostension limb, test all around to differentiate between radicular sensory loss and glue and stock. Now we will examine about NB. There are two types of sensation, deep and cortical. Beyond the scope of these notes, for details see postgraduate clinical pediatrics. Now we will examine examination of coordination, finger to nose test, finger to finger test, examination of back and spine, examine for swelling myoilomenogastrially, a present in association with hydrocephalus or null cherry malformation. Examination of cranium, examine for heat of hydrocephalus, heat circumference, macrocephaly, widely open anterior frontal and widely separated suture. The scalp skin is shiny and scalp veins are prominent. In severe cases, the eye is deviated downward, sunset eye sign as we shown in the figure. Now we will are coming to the examination of the neck. Examine for sign of meningeal irritation. Diagnosis: hydrocephalus, cerebral palsy, cause of CP, type R, spastic athetoid, etc. Anatomical hemiplegic, quadriplegic, etc. Associated neurological disorder are seizure, MR, etc. Example are post-encephalitic specific hemiplegic CP associated with seizure, MR. Progressive muscle weakness, Duchenne Ronosty dystrophy. Summary or examination: state of conscious and orientation, speech, cranial nerve examination, motor system inspection, muscle tone, muscle power, reflexes, motor system, sensory system, test of coordination, examination of back and spine, examination of cranium, examination of neck. Goodbye, dear ladies and gentlemen. If you like my lecture, please subscribe and share with others.